Hi folks, welcome back to Dental Trauma mini lecture series. You've made it, this is the last one in the series. Today we will conclude the series by going through avulsion injuries. This is Navid from Edinburgh Endodontist. For those who've not followed these lectures, we've covered traumatic dental injuries in two batches, fracture injuries and luxations, all numbered in YouTube channel for the ease of referencing and recap. Please watch them all and visit Dental Trauma UK website members area to watch the clinical videos and get CPD. Today we will cover avulsions, and next week I will put a couple of short summary lectures on splinting and root canal requirements for traumatic dental injuries. Avulsion is a total displacement of a tooth out of its socket. All nerves and vessels at the apex and PDL are severed. So apical bundle is completely cut off, PDL is cut and torn, and the root is exposed. Radiographic examination reveals an empty socket, a possible associated dentoalveolar fracture, and sometimes apical third root fracture fragment. You can, for example, see in this radiograph that the tooth had sustained a root fracture, that one, and the coronal fragment has been avulsed, and the apical third is retained. So this is not unusual in root fractures, so that you can get the coronal fragment completely avulsed. In primary teeth, you just leave it. Reassure the patient and the parents, never replant the primary teeth. In permanent teeth, however, it really depends on first stage of root development, so if you have an open apex or not, and second on extra-alveolar dry time, which is the time since the tooth left the socket and exposed without being in any transport medium. So the dry time is very important, and these two dictate how you're going to manage the avulsed teeth. In open apices, we hope to get revascularization and maturation of the pulp and the root. This is the aim of replantation of these teeth. If you don't get this after replantation and observe two signs of infection, so the maturation does not happen, the revascularization does not happen, and you get two signs, you observe two signs of an infection and necrosis of the pulp, you need to start root canal treatment. However, to begin with, you do not. So in open apices, if we come back to prognosis and extra-alveolar dry time, but in open apices, if the tooth is to be replanted as soon as possible, you do not consider root canal treatment. Okay. But the first thing you have to do is to replant and splint, obviously. In closed apices, do root canal as soon as possible, and ideally within 7 to 10 days after replantation. So before the actual splint comes off, you need to do that. The prognosis now really depends on the extra-alveolar dry time and not the actual avulsion. Okay, so it's already happened, the tooth is out, but how it's gonna fare, it depends on how long it's been outside of the socket in no transport medium whatsoever. And that is why we emphasize on the importance of pick it, lick it, stick it protocol and the campaign itself. So the sooner the tooth goes back to the socket, the better the prognosis. So the tooth that is replanted within 5 minutes has got the best outcome, okay, if it is held and handled by the crown. So within 5 minutes, which means as soon as possible, has got the best outcome. And following repositioning, the patient should bite on a piece of handkerchief or something like that and go to the dentist as soon as possible. So you need to educate all your patients and their families, as this is not really going to be done by a dentist unless it happens in sports sort of event and you've got a dentist present, then it is not going to happen by the dentist, this 5-minute rule. So you need to rely on the community awareness to be able to achieve this. Then on presentation, when the patient comes to the dentist, you verify the position and put a splint on for 2 weeks. But this immediate repositioning is really a community thing, a 5-minute rule. So you need to educate your patients and the families. And also the schools, the sports clubs and all that, we really need to do this community education. However, now, if the tooth cannot be put back in the socket, it should be stored in Hank's Balance solution or milk. Water is no good. Schools and sports club hopefully all have Avulsion kits, but if not, milk will do. Some suggest saliva, and all, trying, because there's always a risk of, the patient swallowing the tooth and all that. And milk or Hank's will be the best. With milk, the evidence shows that they keep the PDL cells viable for up to 6 hours, but don't push it. The tooth needs to be put back in the socket as soon as possible, and the dentist visit is really urgent. On arrival, the tooth should be rinsed, so handle it by the crown, rinse the root with saliva, and replant under local anesthetic. If you've got some blood clot, you can just get a flat plastic to remove the clot to aid the reposition. Provide a temporary splint, as discussed in previous clips. I don't want to go into that. You all know the splinting by now. Take your check X-ray, and if repositioned correctly, you can splint using 0.018 stainless steel ortho wire. Now, if the tooth has been out of socket and been in no transport medium or been left in water for over an hour, you need to do root canal treatment first, if possible, please, before placing the tooth back into the socket. So that's it. The tooth has had it, the PDL has had it. So you need to do root canal treatment beforehand, outside of the mouth. And then, but like if you can, for whatever reason, and time it does not permit, then fine, do the root canal after or as soon as you put the tooth back into the socket. But if you can, it would be a lot easier to do it outside of the mouth as opposed to inside the mouth with the splint on and all that. In addition, you need to remove the necrotic PDL, because after an hour, that's it, it's had it. So you need to remove the necrotic PDL before repositioning. And there are a couple of things you need to do. First, soak the tooth in bleach, strong bleach, up to 5%, and for 5 minutes. And then place, after put it in bleach for 5 minutes, strong bleach, remove it, put it in a 2% sodium fluoride for 20 minutes. And that is to reduce the possibility of inflammatory root resorption. Because now the aim is to get replacement resorption and retain the tooth. So now we are going down the route of ankylosis as PDL is gone. Then replant after you go through all these phases. So hopefully get the root canal done outside, bleach and sodium fluoride, and then replant, check X-ray, place a flexible splint for 4 weeks. And as I said, root canal again, either prior to replantation or as soon as possible, up to a week. We say a week to 10 days, but the sooner the better. For both mature or immature, so it doesn't really matter now. If the tooth has been left outside of the socket dry for over an hour, then it does not really matter anymore. You will need to get the root canal done as soon as possible. And then soak in the bleach, put in sodium fluoride, and splint for 4 weeks. Some may say, why bother replanting if the prognosis is poor? Well, evidence shows that in terms of psychological aspects and perspective and dental care aspect, every attempt should be made to replant based on extraoral dry time and following appropriate method, obviously. Okay. Advise and inform the patient and parents about the prognosis. So if the prognosis is poor, let them know, but also do your best. I'll come back to when you should not replant, but apart from that, every single attempt should be made to replant, even if the prognosis is poor. But you do your best, okay, as you always do. The aim is to allow bony healing and tooth retention for as long as possible until a predictable replacement can be done. In teens, you should retain it until they reach adult levels of growth and then consider a definitive replacement if appropriate or required, because it may not be required. You know, if it, obviously it is an immediate replantation, may have a very good prognosis. So it all depends. But in teeth with poor prognosis, try your best to replant, but advise with regards to the poor prognosis. In growing patients, as ankylosis is very likely in these sort of circumstances and can lead to infraocclusion, a careful monitoring is essential to diagnose the infraocclusion as soon as possible, and a referral then to a pediatric unit is advised to consider intentional decoronation to prevent stalling in alveolar bone growth. So if you get this, infraocclusion, then obviously the alveolar bone growth has stalled, and then the restoration of that is going to be extremely difficult and challenging. So as soon as in teens especially, as soon as you get a hint of, okay, this is happening, refer to a pediatric unit. And what they will do, they decoronate the tooth, they remove all the enamel, they bury the dentin so that the bone, the alveolar bone, will resorb the root, and then the level will be maintained for future restorative work. So here you can see upper left one is being repositioned and held with triad, the resin that you can see it inside the ledges as a temporary splint, or you can use composite or green stick, whatever you want. Check X-ray, then splint, root canal is done. So check X-ray, splint, one good tooth on either side, and root canal treatment here. In this case, you can see before the removal of the splint. So all excellent so far. In terms of antibiotics, it is questionable, especially for immediate replantation. So we don't really recommend it if it's being put back in as soon as possible. But if delayed, then you could prescribe 100 milligram doxycycline twice a day for a week. So 100 milligram doxycycline twice a day for a week. But in children over 12 and adults, that is to reduce the risk of root resorption. Obviously, check the medical history and BNF just to make sure that you are updated with all the advice. In children below the age of 12 or pregnant patients, you should not use doxycycline for obvious reasons, for staining. So there's risk of staining. In these sort of circumstances, consider penicillin or amoxicillin if the patient is not allergic, or erythromycin if there's penicillin allergy. But always check the BNF for the most up-to-date advice, because what I'm saying now is what is happening right now. So make sure before any prescription, check the BNF. So in summary, If tooth is already been replanted, if it's already in, just verify the position, splint for a couple of weeks. If closed apex, root canal as soon as possible. If not, you just keep monitoring the maturation and revascularization of the tooth. So if it is maturing, that means that it's got blood vessels inside the tooth. The best way to do it is by comparing it to the neighboring teeth. If dry time is less than an hour, it's been less than an hour, clean the root with saline, handle by the crown, replant, check the x-ray to make sure that the position is correct, splint for 2 weeks, consider antibiotics, and if apex is closed, root canal as soon as possible. If dry time has been over an hour, now the PDL is gone. Soaking 5 minutes, 5% bleach, strong bleach, and then 2% sodium fluoride for 20 minutes. Root canal, no matter whether you've got a mature root or open apex or whatever, do the root canal, and ideally outside of the mouth. Replant, do your check x-ray, splint for 4 weeks in this sort of, so because you are going down the route of ankylosis, now is 4 weeks. Consider antibiotics, advise that the prognosis is not going to be great. For endo, again, said it so many times, try to do it as soon as possible, or even better, outside of the mouth if you've got over an hour extraoral dry time, or if you've got a closed apex that's been replanted. You can do single visit in these sort of circumstances because the time is not be that long for the tooth to go necrotic. So single visit will be fine. And then in teeth that have been out of the mouth for 2 weeks, or teeth that come with delayed presentation because of the risk of resorption, which is going to be in this sort of circumstances inflammatory type, try addressing multi-visit and use odontopaste in these scenarios. It may be useful in reducing the risk of inflammatory root resorption. But again, if it is an immediate presentation, just do it as soon as possible. Single visit will do. However, if it's a delayed presentation, then yes, you can use a dressing which has got antibiotic corticosteroid. Now, when shouldn't you replant? One, we already discussed it, primary teeth is a big no-no. Do not replant primary teeth. Two, permanent teeth, when you've got some other, serious life-threatening injury. So you're not going to spend time on teeth when the patient has got life-threatening injury. So the patient needs to go to A&E to get that addressed. Three, when you've got a tooth that is got extensive caries, or there is a severe periodontal bone loss, there's no point in replanting these teeth. And 4, if there is a medical history contraindication such as immunosuppression. Also ask with regards to tetanus jab, especially if the root is soiled outdoors. So ask that. What I usually do is that if the tooth has been left in playground or something and it looks soiled, ask the patient, the parent, on the update of tetanus jab if they've never done it, which is very rare, but if not, consider sending the patient to get a tetanus jab. Okay, folks, thank you so much for watching and listening to these mini lectures on traumatic dental injuries. I will put a couple of summaries on splinting and root canals soon, so watch the space. Please check Dental Trauma UK website, become a member. Please, is cheap, £30 a year, and use all the benefits that are listed here. Also, there's an annual conference in London, which is very helpful. So make sure that you subscribe and make sure you attend the annual conference. Stay safe, take care, and goodbye.